All right, excellent. All right, hi everyone. Welcome back to another edition of Lenox Hill's webinar series about brain and spine health. We've kind of changed the narrative a little bit. It originally started as coronavirus in the brain. It's set up as a forum to provide, emotional and health and wellness support for our brain tumor patients. But hopefully, based on the news we're on the mend from this. And so as we progress through this period of recovery, we still want to be there for our brain tumor patients. And today we have two very special guests to kind of talk about both their experience during the pandemic, as well as, their hopes and efforts for recovery. So I'll let you guys introduce yourselves. Rohan, why don't you start?
Thanks, Randy, and thanks for hosting this. It's a great service for our patients and their caregivers. My name is Rohan Ramakrishna. I am a brain tumor neurosurgeon at Weill, Cornell, and New York Presbyterian Hospital here in New York City. And, as Randy has done very well over the last several weeks informing you guys, we've had a incredible, weird experience with this pandemic here in New York City. It's really forced us to reinvent medicine in a lot of ways in terms of how we deliver care to our patients, not just in neurosurgery and neuro-oncology, but across the spectrum of medicine itself. In our particular hospital, we had to convert many of our ORs to makeshift COVID ICUs. And so what that did was severely limit our OR access. Again, not just for neurosurgery, but across all surgical specialties. And so we've had to be very thoughtful about what patients we bring to the operating room and for what indications, being mindful that we want to really take care of those patients that need urgent or emergent care expeditiously, but also put off those cases where you want to minimize the risk to the patient from entering a hospital and potentially contracting COVID from hospital access, et cetera. So we try to be thoughtful about how we adjudicate each case and decide which cases to bring into the operating room to use our curtailed hospital resources. But the good news is things are getting better, as Randy alluded to. We are slowly ramping up our volume in quote unquote elective neuro-oncology care to the extent that we consider any neuro-oncology care elective. And that's good. But I think what patients should realize is that it won't be just an on-off switch in terms of going back to normal. I think we have to brace ourselves for a new normal where, things will progress gradually and at times maybe even haltingly slow, but nonetheless, I think things are moving in the right direction.
Absolutely. Thanks for that. Jason, you want to introduce yourself and give us a little bit about how the pandemic has treated you in your practice?
Yeah, absolutely. I want to echo Rowan's comments that this is a wonderful forum, and I appreciate putting it together. I think that this is important both for our patients and for our trainees and affiliated providers. So I'm a neurosurgeon at the University of Virginia in Central Virginia, and we are a reasonable sized practice in a suburban setting. And we've had a little bit of a different flavor to COVID than I think clearly it's different than what has occurred in New York, but nevertheless, we've been affected. We've had to adjust our OR schedules and our clinic schedules to use more efficiently our resources, and I think it's gotten me to become much more accustomed to things like telemedicine approaches for assessing patients, particularly in follow-up, to being more careful about our utilization of OR time. For instance, there are cases that we did end up inevitably in consultation with the patients postponing, and some of those cases I think were reasonable to postpone, whereas others were not and had to proceed. So that in the month of March, we were really pretty busy. In April, I think we hit about 60 to 70% of normal volume. And then we're starting to creep back up again in terms of trending towards normal volume, but not quite getting there, I think, this month. There is certainly a fortuitousness to the fact that we were building a new wing to the hospital. And so in a heroic measure, the health system opened up that wing to the hospital sooner and really began to sort of sequester COVID patients who needed intermediate and ICU care in that part of the hospital. So it allowed us to, I think, provide a more safe environment for those patients that we were continuing to provide care for on a more urgent basis or even emergent basis. One of the challenges, of course, is that we've shifted a lot of our volume, and as Rohan and you know, that neuro-oncology patients can only be shifted for but so long, and that there is ultimately going to be a potential detriment to waiting for some of these patients if we don't get to them in a reasonably timely fashion. And then there's a general perception, I think, by patients, a reluctance, if you will, to come back for certain types of care, or to potentially to postpone this. And it's one thing to postpone for instance, perhaps a knee replacement that was, or a knee arthroscopy. It's another thing to postpone a meningioma for that may be adjacent to a critical structure or cranial nerve, and then someone becomes symptomatic, and it's far more difficult to reverse those symptoms once they've occurred. So it's been eye-opening, and I'll also throw out that I think the challenges of graduate medical education have never been greater as we look at what has occurred in terms of our case volume. It certainly has affected the operative experience of our graduate medical education trainees, residents, fellows, and medical students in a big, big way.
Yeah, absolutely. We actually got a few questions about that. Maybe we can touch on it a little bit towards the end of the talk. I think what I've learned from doing this webinar series that's really critical is you're coming from different regions. Obviously, Rohan and I are in a similar region. We're really kind of in the epicenter. We're literally a few blocks away from each other. But it's nice to hear how other people outside of this region have similarly been affected. And it's also good to get your kind of perspective on the whole thing. And so you said that your practice essentially, kind of came to a halt at some point as well, and now is ramping back up as the hospital, put into place measures that would kind of limit the spread, right? The same thing every hospital system did. So during that time where your community is not really inundated with COVID, what kind of messages from patients were you getting? Were patients worried about coming to the hospital? I'm sure Rohan and I, our patients don't want to get MRIs. They don't want to come near the hospital. They've been very on board with telemedicine as much as possible, or as much as you can be. Have you had a little more anxiety in Virginia versus, let's say, New York?
I think there's a heightened anxiety of patients, particularly patients who may be on immunosuppressive agents. For instance, patients who are receiving chemotherapies and targeted therapies for metastatic cancer, they're very, very hesitant to come to the hospital if they don't need to. But of course, a lot of the ways that we measure success or failure is through imaging studies. Obviously, the clinical exam is important too, and a detailed history taking, but the absence of getting a scan is, you may be, as you know, missing things. So patients are reluctant, but many patients, I think, now are beginning to accept this new normal that we live in, and we've put in place a lot of measures to try to reassure patients that once they come to the hospital that this is probably a safer place to be than, in many ways, the supermarket that they're going to have to go to pick up their groceries.
Or the beach. Rohan, how about you? What kind of phone calls are you getting from patients? What have you heard is the primary concern of people? Is it they don't want to do their appointment, they don't like telemedicine, are they disappearing, or are they really staying in contact with you during this time?
I think it's a mix. People have, in my experience, embraced telemedicine and enjoy the convenience of it. I think there's no going back, honestly, from the standpoint of now that patients have seen it and have experienced it and like the convenience of it for particularly follow-up appointments. I think that's going to become and remain a sizable portion of my practice, outpatient practice, is seeing patients via video visits. So I think that's been a blessing in disguise. If there's a silver lining to this, is it just makes everyone's day more efficient from both provider and patient if you can integrate telemedicine effectively. I think another subset of patients have, they feel well, and they're not too worried about their MRI being delayed a month or two for particularly benign, quote unquote, benign disease in neuro-oncology. And so they've actually not been calling because they're comfortable just being at home. And then of course there's patients who, particularly with gliomas or brain metastases, et cetera, that we've had to think carefully about when to do follow-up imaging and how to, take care of them in this resource challenge setting. So I think it's a mix of all those things that I've experienced anyway.
Yeah. So I want to talk a little bit about the manuscript you guys put out. And obviously it was published in the Journal of Neuro-Oncology, which Jason, you're editor-in-chief of right now. And so what was the thought process behind initially kind of conceiving it? Does that stand as the tumor section official policy on these things? Has there been an official policy? Why don't you guys talk a little bit about the thought process and what went into it?
Sure.
Yeah.
Oh, go ahead. Sorry. Just.
No, I was going to say first, I'm pleased that Journal of Neuro-Oncology was the first neurosurgery represented journal to have anything out in print that really addressed COVID. Yeah. We were the first, and Rohan led that manuscript, but I think it represents as close to a set of recommendations or guidelines at the time from both the NS CNS tumor section as well as the Society for Neuro-Oncology. But Rohan, why don't you talk a little bit about the manuscript that ultimately got published and I think was the first paper out in any peer-reviewed neurosurgical journal?
Sure. I mean, I think as we were all, experiencing this surge of patients and this complete stoppage of our normal work, it became obvious to me that other centers were going to go through this and had to figure out quickly how to manage their workflows as it pertained to dealing with neuro-oncology patients. And I think nobody is going to be a better advocate for our patient population than the doctors and providers who take care of these patients on a daily basis. And so I thought it was important that we as a community put out a framework for thinking about how to adjudicate our resources and manage patients in this challenging time. I think when we wrote the article, it was sort of at the upslope towards the peak of the pandemic here in New York City, and it was important to us to get that out quickly so that it'd be useful at the right time. Obviously, there'd be no point in publishing it when the pandemic was over. So I think that was the impetus for writing the article, and I hope that providers, even internationally, find it, useful for figuring out how to manage their patients in this time.
Yeah, absolutely. Actually, you guys were the first without a doubt, and I know that because we submitted a separate article that was similar. Ours was a letter to the editor. It was ultimately published in Neurosurgery, and the ideas are the same. And it was basically the same feeling that you guys had, which was that, neurosurgery patients are a unique population of people. This isn't, like you mentioned before, Jason, a knee that you can kind of wait on. This isn't even really back pain, which is still urgent. This is a growing tumor that needs to be addressed. And how do you address that safely, and how do you keep the patient safely? And so, I read your article when it came out, and that's why I was so intrigued to have you guys here, especially because, like you said, when it was originally written, we were on that uptick towards the peak. And now as we kind of come over that, we're starting to have cases going. We're actually, John Bookvar is doing a clinical trial case right now. And so we've opened up. We had, I think this is our 6th tumor this week. So, and that leads to 2 questions really. Number one, how do we structure that recovery now with regards to the neuro-oncology patients? And then number 2, are we going to see an increase in patient, coming in with brain tumors at this point because they've been sitting there, you know, not telling anyone that they had symptoms for so long.
Well, I certainly think that the latter is going to be true, that some patients are going to have postponed coming to their local physician, who would then have ordered a scan, who might have caught something a month or two or more ago. But I don't know that, you know, I've had instances where patients who have had symptoms with shunts, and they've waited longer than they ordinarily would have just because of the fear of coming into the ER to be evaluated. And so there is inevitably going to be we need to reassure patients that although there are risks to coming to the hospital, that there are also risks for waiting too long for some of these urgent neuro-oncological and neurosurgical problems. And I do think that we need to make the hospitals as safe as we can for them. But in terms of stratifying the sort of recapturing those patients that have been postponed, we need to be, I think, thoughtful about how we schedule these patients, particularly prioritizing those patients that have more of the malignant tumors first and foremost, get those done. And I think we're slowly working on rescheduling of patients in my practice in as thoughtful a way as possible. But there are challenges to that. And obviously there's a finite amount of resources that any of our hospitals have in the best of times, and that we're still not there in terms of our full normal allocation of OR time. So imaging time is still not quite what it ordinarily would be. So we're not yet through the pandemic, clearly, and then there's the lingering concerns about whether or not there'll be a second or third wave of this in the months to come. We just don't know.
Rohan, anything to add to that? You're muted. Sorry.
I think Jason said all that very well. You know, in New York City, I was just at a grand rounds a couple of days ago at this notable epidemiologist, and what he said, interestingly, is that you know, New York may have a seroprevalence rate much higher than we expect. You know, like 40-ish%, which would mean that though we were late to containing this virus, because so much of the population has been exposed, we may not have as horrible a second wave as people are you know, frightened about in the fall and the winter. So if, you know, though it was bad that we didn't contain it at the beginning, I think hopefully there's going to be some, you know, silver lining to that coming forward.
Yeah, I mean, you know, one thing we've stressed pretty much, I think, weekly since the webinar series has started is that people have this fear that they don't want to come to the hospital. They have this fear that they don't want to get their imaging done. But they need to for certain things. Imaging, like you mentioned, is first and foremost. Radiation, chemotherapy, labs getting drawn, although there are options for that. You know, we have this incredible experience now dealing with this, and the hospital systems in New York City have moved so quickly. And I think at this point throughout the country, as they've kind of learned from the steps that, you know, Northwell, New York Presbyterian, NYU, these major centers have taken while dealing with this here, that we're actually, like you said before, pretty safe. We have, you know, triaging phone calls, screening, there's testing protocols, there's masks given at the door. We keep patients separate. We have separate floors for different patients. And so I think that, you know, as we move into the recovery phase, in a way, this is the safest place to be, especially if you're a patient dealing with cancer when you are more at risk. And I think the key to that is just keeping the lines of communication open with your doctor, getting in touch, you know, making sure you have a plan of how you're going to take care of what's going on. And then, you know, giving trust into that system that's worked so hard to kind of establish these rules and guidelines. And, you know, I think that we've opened up, we're obviously, I wanted you guys to talk about your experience. We're doing similar stuff here. We have telemedicine fully unfurled at this point. And I love it. I mean, I was seeing a patient in the OR core today, And so, you're with it, you're available at any time. You can get online, you can, have a conversation, you can see someone, you can kind of calm their fears and their, anxieties, as well as review their films and come up with a plan. And I think it's extremely powerful. And so I'll actually use that to transition into the stuff we talked about before with the education issue. So tech is being incorporated, universally at this point. I think I'm one of 600 neurosurgeons with a webinar at this point. I think I was one of the first, but just saying, it's widespread, and I think it's great, right? It's education. At any minute of the day, you can basically tune in and find something you didn't know out previously. And so surgery is a very hands-on educational experience. You need to train residents. And so during this time, what are your institutions doing to make sure residents are getting the training? Number one, there's a paucity of cases, but number two, how are they, what are they doing within the institution to guarantee that they're still maintaining their education and learning? You guys are both muted, I think.
Yeah. I mean, look, I think right now the case volume isn't there, so that part of it is temporarily slowed down, and we hope it's as temporary as can be. In the meantime, though, I think webinars like this and the countless other educational experiences that have moved online have been, in a way transformative in terms of resident education, because now, you have these massive webinars for spine or, spine deformity or brain tumors, where you have experts from around the country talking about cases. And I think that wasn't really a thing that was available to residents before all of this. So on some level, I believe all things will continue on some level moving forward because they've become so popular. And then the other thing is just, we have our skull-based lab for our residents here, so we encourage them to use that. And I think that's been a nice way for them to practice approaches to the brain and skull base and, learning the anatomy.
Yeah, I echo what Rohan had said, that I think that many societies and individual neurosurgeons have really stepped up to offer high quality webinars such as yourself. And it's marvelous to be able to see and to have visiting professors, if you will, that can come and talk to your residents, and then to do so at a particular time of day, or to do it on demand, and to hear thoughtful case discussions in the most high quality fashion, and yet in a very cost effective way. So I think that's been a big plus, that we can see that there ought to be more web-based education for residents. And on the flip side, I think that hands-on operative experience is the thing that has suffered. And one of the challenges is that we've really limited observership in cases. So a chief resident may help me with the case, but having a assistant resident there to help is really not something that we've advocated because of the increased risk, as well as the increased utilization of PPE, that we just didn't want to burn through the PPE as quickly. And so that those residents are being discouraged from scrubbing in when they might otherwise have scrubbed in normal times. And we're also seeing that there are going to be some changes probably down in the pipeline in the summer and fall, where visiting trainees who might come here for a couple months or a couple weeks even to observe may not be able to come, or they may not be able to observe if they do come. And I think that that's detrimental, but there are going to be some ways to web-based approaches and web-based education, I think, that we can overcome some of those limitations. So I remain optimistic that in the end that our residents in the U.S. are some of the best trained neurosurgeons in the world, and that this relatively short period is going to be not a detriment to their overall training.
Yeah, absolutely. I think one thing that's been shown, at least by, and I'm sure, Jason, you know this, but the influx of papers that have come in regarding COVID is neurosurgeons don't like to sit down and do nothing. So education platforms, a lot of innovation is going to come out of this. And I think, Rohan, you said it at the beginning that times have changed and we're not going back to the way it was. There's going to be some incorporation of the stuff that we've put together here rather quickly into our everyday and a kind of, and you know, as everyone discusses this new normal. And so I think it's fantastic. We've had a great time, you know, a lot of projects here at Northwell thinking about how we're going to advance moving forward, embrace technology and get back to business as usual or whatever that usual is. And so that's great. What are your thoughts on the med student issue? I mean, med students now are not able to rotate through. So is that going to create an issue where you know, how do you match people into neurosurgery? How do you pick people correctly when you don't get to meet them or spend time with them?
Yeah, I think it's a big issue and not one that we're necessarily going to, you know, have a great answer. I haven't seen a great answer in terms of a substitute internship, which has been such a critical part of residency training and applicant selection, you know, for the last several decades. I mean, nothing beats the 1 month experience you get with someone versus, you know, just the 30 or 20-minute interview if they don't rotate at your institution. And, you know, I think the other thing that concerns me about not having sub-Is is, you know, there's some institutions that don't have a home neurosurgery program. So what's going to happen to those applicants that are interested in neurosurgery where they don't have the benefit of having a home program where neurosurgeons can write letters for them? So I think that's something that's going to have to be worked out, you know, thoughtfully. I know the residency program directors are, the SNS and our societies are working diligently on that. But I do have a big concern about that for sure.
Yeah, absolutely.
Yeah, I agree. I think that there's no easy replacement for an acting internship or rotation at a program to really get to know that resident applicant, as well as for that resident applicant to understand the flavor and feel of that program. And let's face it, I mean, most neurosurgery applicants are highly intelligent, very well qualified, and so they'll succeed. It's really just a matter of what program is the best fit for them and what the program decides is the best fit for that particular program in terms of a resident applicant that they'll end up taking into the program. And so that one-on-one interaction is really going to be hard to duplicate through web-based interviews or speed dating type interviews. Like we're just not going to be able to do that.
Yeah, I think there's going to be a lot of hurdles to get there. It's going to be a tough year for the neurosurgery match, but I think, you know, it ultimately, it works out. I think, like you said, they're smart, ambitious people. They find ways to make themselves known and you know, show their qualifications for things. I know we're actually doing a virtual internship this summer where we're going to be actually opening it up. We typically have a tiered system: high school, college, medical school, and we're going to enable you know, access to our conferences. I mean, it doesn't cost anything, right? It's easy, like you said. Where basically the students can come in, they can get educated, and we can, you know, continue our training, our education kind of, you know, agreement that we have with the medical school and these colleges and people to train the future of neurosurgery and people interested in science and research. And so that's kind of how we're moving forward with that or looking at it. Listen, I think this has been great. I appreciate your guys' time. I try to keep things around 30 minutes. Is there anything else we didn't touch on that you guys want to talk about? I know you're both very busy, and I think it's fantastic that you guys came along.
I thoroughly enjoyed the discussion, and I hope that the participants on the line have had some of their questions answered. I think that you know, this is such a fast-moving situation. It's not anything that I've ever learned about in medical school or in residency, but you sort of pick up along the way how you have to adapt your practice and your educational programs and all. And I think that, if anything, neurosurgeons have proven themselves to be incredibly innovative at dealing with this situation. So, and some of the things you've talked about, I'd love to hear more, and we can talk offline about the internship that you're talking about. Something that could potentially be translated to other programs, including my own.
Absolutely, yeah.
You know, I would echo everything Jason said. Thank you for putting this together and inviting us. I think a final message to patients would be, talk to your provider, stay in good communication, because communication is ultimately the most important thing, so we can figure out plans together and navigate this challenging period we're in. And I think if you always reach out, there's no substitute for that. And I think we'll all get through this together without a problem.
Great. Thank you guys so much. I look forward to the next publication about the recovery.
Coming out soon.
Yeah, coming out next month.
Yeah.
I hope so.
Yeah. All right. Thank you guys so much. Have a great evening.
Thank you so much.
Thank you.
Thank
Take
you.
care.
Yep. Bye-bye.
Bye.